this module, we will be discussing adult mental health. Mental health presentations to a health facility can be due to mental health illness in one extreme and mental health problems at the other extreme. When someone has a mental health problem, he will be feeling sad, anxious, stressed due to a problem in his day-to-day social life. Examples include grief and domestic violence. Whereas mental illness affects a person's emotions, thinking pattern, and ability to function over a long period of time. Mental illness, biological origin, in addition to the contribution of social and psychological factors, and needs specific treatment. Examples include schizophrenia and bipolar affective disorder. Due to the association of biological, social, and psychological factors in mental illness, we analyze mental illness through a biopsychosocial model. When discussing about mental illness, we have to understand the meanings of illness and disease. Disease is the deviation of the condition from normal structure and function. It will result in a specific collection of symptoms and signs which enables a diagnosis and a treatment plan. Illness, by definition, refers to how patient understands his illness. As patients present to healthcare facilities with symptoms, we will try to start with symptoms and understand how to reach a diagnosis. First, we will see regarding a patient coming with suspiciousness. Suspiciousness can be mainly of two types. Patient can be unduly jealous of their partner, or they can be suspicious that others are plotting to harm him and watching him, which is called paranoia or paranoid. Persecutory carries a similar meaning. Suspiciousness arising from jealousy towards partner leads to morbid jealousy. Morbid means unhealthy and affecting normal functioning. If the jealousy amounts to a delusion, and if the jealousy is the only pathology, we call this condition a delusional disorder jealous type. Similarly, if there is a single paranoid delusion, we call it a delusional disorder persecutory type. In schizophrenia, there will be delusions of various types associated with other features including hallucinations. Suspiciousness can be due to other conditions like organic illnesses, recreational substance abuse like cannabis, and even part of some personality disorders. Delusions are firmly held beliefs reached on inadequate grounds which patient does not change on rational arguments or on evidence for contrary, and cannot be explained by cultural, religious, or educational background. Hallucinations are perceptions patients experience without a stimulus. This is commonly auditory, but can occur on other sensory modalities like vision, touch, taste, and smell. Schizophrenia is a relatively rare but serious and chronic psychiatry illness. It usually presents with various delusions and hallucinations which are called positive symptoms. Patient can develop depressive or manic symptoms as well. If not effectively treated, early patients develop other symptoms like inability to express emotions, withdrawing from society, no motivation to work, and reduced speech. These are called negative symptoms. With the course of illness, patients will develop various cognitive deficits as well in areas like memory, speech, and interaction. You may have heard the term psychosis. This includes illnesses where a patient loses contact with reality. Usually, we say a person is psychotic if they have delusions or hallucinations. There are two important things a primary care doctor should do if a patient presents with suspiciousness. First, you have to assess if there is a risk of harm to others by the patient and act accordingly. Second, you have to discuss with relatives regarding the possibility of serious psychiatric illness and the importance of proper treatment. Mainstay of managing a patient with suspiciousness is to treat the underlying cause. For this, please refer the patient to a mental health team. Now we will look at a patient with elevated mood. When a person is having a pathological elevated mood, he feels jolly and on top of the world. However, to others, it would be obvious that the person is not well and has deviated from his normal self. A patient's emotional state is important in psychiatry diagnosis. Emotion has several components, including how one feels interacting with a matter or situation. It has three components: how one feels, how one reacts behaviorally, and the psychological reaction. You can be sad, angry, or happy due to something. Mood, on the other hand, is the prevailing state of emotions. It is not related to any particular stimulant. You may feel just happy, low, depressed, anxious at a particular time. The term affect describes how emotions varies towards a stimulant. It could be reactive, that is, change with stimulant as expected, or labile, which means changes rapidly. There are several possible diagnoses when a person presents with elevated mood. The most common one would be mania or hypomania. Mania or hypomania is a way of presentation of underlying bipolar affective disorder. Bipolar affective disorder is a chronic illness where patients experience episodes of mania, hypomania, and episodes of depression in between normal periods. In a manic episode, patients experience several symptoms. They will have an elevated jolly mood. Some are angry and irritable. They have increased energy with overactivity, overtalkativeness, less need for sleep. They may not care for social norms with their behavior and act recklessly. They would be grandiose with expansive ideas and plans. Manic episodes disrupts patients' ordinary work, lasts over 1 week, and relatives would say it is difficult to manage him at home. It might contain hallucinations or delusions. In contrast, hypomania is less severe and will not need hospital admission. Assessing a person with mania would be difficult as patient gets easily distracted and is disinhibited. Assessor has to be firm, polite, and understand that the patient is ill. First need is to assess the risk and manage aggression and agitation. You will have to talk to relatives and explain that this is an illness and not to argue and react to the patient. They will have to be aware of risk situations like violence, overspending, and sexual promiscuity. After managing aggression, please refer to specialized mental health services. Now let's see how to manage an aggressive patient. Ideally, managing an aggressive patient should be done in a PCU or similar setting. The safety of staff, patient, and community is the priority. If you are in doubt, contact the mental health team first. First, try to talk to the patient and calm him down. Most patients who appear aggressive calm down when talked to in a non-threatening manner. This is called de-escalation. In time, we remove the agitated individual from the high stimulating environment, which could be the relatives or busy ward setup. This technique is usually used with children. Some psychiatry inpatient units have seclusion rooms to place patients till they become calm. If talking fails or appears inappropriate, we will resort to oral medications. If oral medications fail, we will have to sedate the patient with intramuscular medications. Now, let's talk about depression. Depression is a common psychiatric illness which can present in various ways. Depression is one leading cause of disease burden globally. Reports indicate a prevalence of 4.5% to 41% of patients presenting to primary care suffering from depression in Sri Lanka. But most of these presentations remain undetected. So always be on the lookout to see if the patient you are seeing is suffering from depression. Some signs may suggest an underlying depression. These include multiple presentations, multiple somatic symptoms, relationship or work problems, changes in mood including sadness or irritability, sleep problems, appetite problems, fatigue, stress, and memory problems. If you suspect that the client may be having depression, directly question him about typical signs and symptoms of depression. Three typical or major symptoms are feeling sad always, inability to feel happiness, and feeling tired. Other symptoms include reduced concentration leading to memory problems, reduced self-confidence and self-esteem, feeling guilt and unworthiness, hopelessness, ideas or acts of self-harm, disturbances in sleep and appetite. Symptoms should last 2 weeks for a diagnosis of depression. However, if symptoms are severe, we may diagnose with a lesser duration. Patients, especially adolescents, may present with irritability. Management of depression depends on severity. Uncomplicated depression can be managed at primary care. Uncomplicated depression includes mild and moderate depression. In mild depression, patient will have two typical symptoms and two other symptoms. They will be distressed due to symptoms, but the functional impairment will be less. In moderate depression, patient will have two typical symptoms and three other symptoms, or they will have four or more of any symptoms. They will experience considerable difficulty in functioning. There are several types we categorize as complicated depression. One is severe depression. In severe depression, patient will have all three typical symptoms and four other symptoms. Usually, they have guilt, hopelessness, low self-esteem, and self-harm ideas. They will not be able to continue normal work. Another sign of complicated depression is the presence of psychotic symptoms having suicidal or homicidal ideas and risks to physical health like refusing food. Not responding to antidepressants and getting recurrent attacks are also considered as complicated depression. Uncomplicated depression can be managed in primary care. Depression management should be corroborative. Patient and family should be educated that it is a common illness which is easy to treat. Be aware that they may fear stigma. Patient may need counseling regarding other problems and healthy lifestyle. Treat any other comorbidities and refer to other agencies like social services, counseling if needed. Mainline treatment is psychotherapy. First, try a SSRI, fluoxetine 20 mg or sertraline 50 mg. See the response in 2 weeks. If not responding, review in another week. If still not responding, consider increasing the dose. Fluoxetine maximum dose is 60 mg and sertraline is 200 mg. If still not responding, try a different antidepressant or refer to specialized mental health services. Treatment should be continued at responded dose for 6 to 9 months for first episode.